So as a neurologist trained in deep brain stimulation surgery, it's very important for me to be in the operating theatre with the patient. The operation is done with the patient awake, and so throughout the process of those several hours in the operating theatre, I'm communicating with the patient, talking about, first of all, what's going on in the operating theatre, but then also getting a sense of how they're coping with the surgery, but more importantly, looking at the targeting strategies we have to make sure the wires are in the right spot. So the targeting starts off by us looking at the MRI scan on a three-dimensional computer simulation and target exactly the right part of the brain, whether that's the subthalamic nucleus, the thalamus, or the globus pallidus. And then once the wire is being inserted into the brain, I take recordings using a computer of the electrical discharges of the nerves in the brain, and there's certain signatures in different parts of the brain that tell me exactly where the wire is. So together with Professor Bitter, we determine where the wire should be left inside the brain according to the signature of the nerve discharges. Then once the wire's been put in place, we send electrical impulses down the wire to try and improve the symptoms, and that can either be improving symptoms of tremor, symptoms of muscle stiffness, or symptoms of slowness of movement, and these can be all assessed on the table and are assessed by me throughout this phase of the operation. This can be quite time consuming, but this gives us the final confirmation that the wire's in the right spot and certainty that there's going to be some clinical benefit and improvement in symptoms once the patient's out of the operating theatre and in my consulting rooms 2 or 4 weeks down the track.